This is an advertisement from BetterHelp. Being a paramedic means bearing witness to some of the most traumatic moments in people's lives. Over my career, I've seen firsthand how the mental health burden of this work can build up. I personally accessed therapy myself, and I can say from my own anecdotal experience that talking to a qualified professional can be incredibly helpful in processing the challenges we face in pre-hospital care. It's easy to think we have a handle on everything on our own, but we're all better when we have a support system behind us. Therapy isn't just for people going through a crisis. It really can be a space to build resilience, learn coping strategies, and develop tools to navigate the emotional weight of our work. So with over 5,000 therapists in the UK already, BetterHelp can provide access to mental health professionals with a diverse variety of expertise in mental health. So build your support system with BetterHelp. Our listeners get 10% off their first month at betterhelp.com/carepod. That's betterhelp.com/carepod. That's CAREPOD. Please also see the show notes for further details. This podcast is sponsored by PACS. Whether on water, on land or in the air, PACS bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PACS bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PACS bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PACS bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PACS bags in a number of critical care situations, and they're absolutely excellent. Please see the show notes for further details.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. This is going to be part 2 of a 3-part series on geriatric care for hospital and indeed pre-hospital providers. And in this episode, we're really going to tackle delirium, confused states, and elderly pathologies. So we're joined again by Iain Wilkinson and James Adam for this episode. Delirium is a common and often under-recognised condition amongst older adults, particularly during emergencies. It can be triggered by a range of factors, including infections, dehydration, medications, or underlying chronic conditions, and presents significant challenges for pre-hospital and in-hospital providers alike. So in this episode, we're going to explore the unique hurdles faced when caring for elderly patients experiencing cognitive changes. From understanding the impact of sensory impairments on communication to distinguishing between delirium, dementia, and other states of confusion, we'll discuss practical strategies to improve assessment and care delivery. We're also going to highlight the critical role empathy plays in building trust with patients and their families during these vulnerable moments. We're going to dive into how pre-hospital and in-hospital teams can align to address root causes of delirium and also ensure continuity of care. We're also going to address ethical dilemmas and family dynamics. And we're also going to look at proactive measures to prevent delirium in at-risk patients. So to do this, we're joined by Iain Wilkinson and James Adams. Iain is a consultant geriatrician and joined us on part 1, as did James, who is a frailty care and service transformation lead. Welcome both to the podcast.
Thank you.
Thank you very much.
I guess initially, Iain, if I could just come to you and just get you to speak to defining delirium for us, if that's okay, and then maybe speaking to some of the common causes of delirium in elderly patients.
Yeah, of course, Iain. So delirium is it's sometimes called an acute confusional state, and it's a common clinical syndrome, and it's characterized by disturbed consciousness, change in cognitive function or change in perception, and generally it's got an acute onset and, really importantly, a fluctuant course. It usually develops over 1 to 2 days, and it's a serious condition that's got associated poor outcomes. It is, however, something that can be prevented and treated if we deal with it urgently and correctly. Practically, though, it's an acute change, so a sudden change in someone's normal cognitive state. It's usually temporary and is reversible. And the way that I explain it to people is it's when the body, in the broadest sense of the term, asks the mind, in the broadest sense of the term, to do more than it can. So if we think about our brains here and now, let's say they're doing 10 things, or they can do 10 things. So one of those things is understanding our posture and controlling the muscles. One of them might be controlling the speed of our heart. One might be controlling our breathing rate and depth of breathing. One might be being aware that in the room that you're in at the moment, it's quite warm and you're sensing that. One might be listening to the sound of our voices and filtering out some of the sounds in the background. One might be, controlling any smells in the room. And then you might have 4 or 5 things spare. So we could have this conversation. You could have this listening at home if you were really tired, if you hadn't slept last night, but you'd be thinking, oh, I'm having to think a bit more. We could have this conversation if you hadn't slept, so using up one more thing, and you hadn't had your cup of coffee this morning and you had a cold, but you'd be now conscious that you're really focusing and working hard. However, if your brain can't do 10 things and your brain can only do 6 things because your brain is much, much older, you're going to reach the point that you suddenly want the brain to do 7, 8, 9, 10 things, and it can only do 6. Can't do that. So it's going to pick and choose what it does. And as a result, you're not going to be able to think entirely linearly. And therefore, from the outside, your thought process is going to go off and you're going to look confused at times. But the cause of that extra strain may go away. If that extra strain is because you're thirsty or you're constipated or you've got a bit of an infection or something, in a few days' time, that may be better. And that's why you have this fluctuant course. The triggers come and go. And so the causes of delirium are anything that puts a strain on the functioning of the brain. And there's various acronyms that we could go through, but essentially it's anything that causes a strain. So someone, if they are a bit dehydrated, or if they have constipation, or if they have an infection, or a new medication, or they've not slept, anything that just makes your brain work a little bit more could, in theory, make you delirious. And it presents either with the hyperactive form, where people are agitated, they may be shouting out, they may be quite paranoid, or the hypoactive form, where people are very quiet, withdrawn. And sometimes you think about this as like an exaggerated response to illness. If you're an older person, me as a 40-year-old person, if I have a cold, what I want to do, I want to curl up in the corner with a Lemsip and I want to be quiet. If you're a 4-year-old, that is not what you do. Everybody knows. And delirium is a bit like exaggerated responses to that. You have the agitated response, and then you have the quiet, withdrawn.
And that's powerful to frame it like that, Iain, because as you said, it's a spectrum of presentations within that corpus of delirium. And I guess from that, I'd like to come to James and just ask, maybe just if pre-hospital providers were looking at differentiating between delirium and, say, dementia and acute cognitive confusion, but mainly dementia and delirium. In my mind, something Iain said there, which is quite prudent to understand, is that delirium has reversible causes. There's a reversible element to delirium, whereas dementia has more of a longevity of decline. But maybe that's not true to say, and I'll get your perspective on this, James, because even within dementia, there is lucid periods. There's periods where, and also Iain said something about, this long-term memory function, which is maybe preserved even in dementia. But I guess my question is, could I get you to put some guardrails and definitions around and differentiate between dementia and delirium?
Yeah, I mean, I think a fantastic overview there from Iain, wasn't it? He basically very succinctly described delirium in a nutshell, really. So we could almost stop there, but we won't. I think it is difficult sometimes to distinguish between the two. So I would say delirium is a risk factor for ongoing cognitive problems in older people. with frailty and dementia, and can progressively lead to a subsequent dementia diagnosis. So we know in hospitalized older adults who experience delirium for the first time that actually their outcome may not be good from a cognitive perspective. So although that's slightly unpredictable, we know in a high percentage, something like 20 to 30%, there's going to be ongoing cognitive deficit there after they're discharged from hospital, and they're going to have to live with that cognitive issue, and it's going to be very uncertain and unpredictable about the recovery trajectory from it. So there is clearly a syndrome of overlap. So pathophysiologically, whatever it is, there's an overlap between delirium and dementia. There's no doubt about it. And actually something we commonly see is undiagnosed dementia that has been trundling along for quite some time in older people, and it's unrecognized. We haven't proactively identified it or diagnosed it properly. And actually the first time it's being picked up is when they develop a delirium episode. And that's clearly not right and not what we want really from our health and care systems, is it? We want to proactively identify at-risk individuals so that we can help prevent and put in those strategies to help prevent deterioration, and certainly to flag them as at risk if something happens to them and they end up with an acute confusion. So all of those factors are important for pre-hospital teams to know, that they actually play a critical role in identifying those who actually live with cognitive problems in general and are at risk before they even get into another healthcare provider. But also they are often the first responder who is there to pick up on the delirium state. And just picking up on Iain's point around the different kinds and the fluctuation between the two, and actually that's almost part of the diagnostic criteria. But in particular, the hypoactive state, I wouldn't miss that. You know, they're the ones who do really badly if it is missed, because often we say, you know, oh, it's an older person who's a bit more drowsy or was a bit tired today, and actually you're missing out on an important diagnosis of acute confusion and delirium, which is potentially reversible. And actually these are clinical emergencies often. We often say that in our teaching, don't we? That like a lot of emergency medicine, delirium is the one that we tend to miss as a key one. And we don't look in depth enough around the potentially reversible causes underlying it. And I would also just relate this to our previous conversations that we had around frailty and poor reserve. So actually, I often teach, you know, this is a frailty syndrome, that you can be physically robust, but you have an underlying cognitive problem. And actually, you have cognitive frailty in that scenario. So you're vulnerable to what, and remember, we were describing frailty and the stressor events that can occur. So actually, any stressor event for someone who's living with dementia as a diagnosis, it can lead to an acute confusional state or delirium, and that's how it will present. And there's an underlying issue there. So a bit like frailty crisis, as we would term it. Actually, this is a form of frailty crisis for someone who has a vulnerable cognitive condition. The other thing I would say is that you don't always find an underlying cause. So actually, you know, probably in about a fifth, something like that, the cause, whatever it may have been, is so subtle that we can't actually detect what it is. That doesn't mean that you shouldn't concentrate on all of the high quality care that you need to manage someone with an acute confusional state. Of course you should. And it doesn't mean that you shouldn't build all of those other things that we're going to talk about, I think, in due course, around involving family members, communication being key, collateral history building, and really finding out in depth what makes that person tick. And so you can build it into your care. So I've rambled on there. I'm not sure if I answered your original question. I can't even remember what it was, to be honest.
Yeah, you certainly did.
It's about delirium and dementia differentiation.
It was, but it was differentiating. And you made a really interesting point there, James, around there could be a differentiated diagnosis, but the two can overlap, because something you said, which is really relevant and interesting, is that someone can have dementia, but can have an acute onset of delirium within that dementia. So there's almost this, and this is where it's prudent to look at the nuances, because there's an acute onset of maybe a focal an infection, urinary tract infection or otherwise, where there's a subsequent dehydration. Now, there might be a long underlying diagnosis of dementia, but there's an acute delirium aspect to that, which is reversible. And maybe that's prudent stressing that there's potentially some element of reversibility to delirium, whereas this dementia there is maybe longevity of diagnosis and of decline over time, but the two can overlap. And I think that's really important to differentiate that you've got to really dig into the history, do a full workup to understand, because I'm sure you could both speak to it, and Iain, I'd like to get your thoughts on this. I've never seen such an acute change in a patient, certainly an elderly patient, when you give a bolus of fluid for someone who's profoundly dehydrated, and seeing their mental faculties return to them, it literally within 30 seconds, a minute, 2 minutes, when you start to give them a profound dehydrated patient intravenous fluid. Could I get you to speak to that?
Yeah, absolutely. I mean, you're quite right. The reversibility of this, when there is a clear cause, can be quite profound, and it can happen quickly. It can also happen slower, and there's definitely a sort of, you treat the thing, we're there, and then actually, the next morning or the next evening, it's worse again, and so there's definitely this fluctuant nature to it, and I think part of that is it's attention to detail, and it's looking for those small causes. As James was saying, the cause, we may not find the cause, but we can turn over a good few stones to have a look. And without going through a whole list of potential investigations, some really practical things. So hydration, removing constipation, hearing and visual loss, trying to treat those. So putting people's hearing aids in, putting their glasses, cleaning their glasses. I spend half my wardrobe around cleaning people's glasses. As someone that wears glasses, the state of glass. Anyway. So I think they're quite simple strategies, actually, that we can all do at any point in that health and social care spectrum of care, that don't require necessarily sort of fancy blood test scans and such like that.
So I'd like to, you mentioned actually sensory impairment, and I'd like to look at that maybe in slightly more detail, such as hearing loss or visual difficulty. Could I get you to speak to, so we'll start to move on to communication. I'd just like to look at sort of communication with elderly patients experiencing delirium or confusion. Could I get you to speak to yourself, Iain, and then I'll come to James, just how we overcome some of these barriers?
So I think when we're talking to older people who have any form of cognitive impairment, whether or not that's acute and delirium or chronic and long-term, such as a mild cognitive impairment or dementia, I think clarity is really important. I think ensuring that people can hear and understand your voice, and modulating your voice to a level and volume and such like that people can do, and not patronizing people. This is not talking down to people. This is not talking to people like their children. This is being clear and making sure that people understand. So checking understanding. Can you hear me? Can you understand what I'm saying? And sort of checking their understanding at the end of any consultation that you've done with them, just as you would do with anybody else that you were having a consultation with. And I think all of those rules still apply. I think if someone has delirium is essentially a disorder of attention, and the domain of attention. And so somebody's ability to maintain attention on the topic will be reduced. And I think, therefore, when you're talking to them, it's important to try and segment up what you're saying to bite-sized pieces, if you know someone that's got delirium. And one of the management strategies for delirium is to keep reorientating people. And so I think a conversation that reminds them where they are and what's happening and who you are, maybe repeated a few times, I think is important. When someone has dementia, the strategies might change slightly. So I think you would still want to be clear and check understanding and all of those things that I said at the beginning. Sometimes reorientating people with dementia isn't always the most helpful thing. If they're calling out for their mother or their father and they no longer alive, then telling them that they're no longer advised isn't necessarily a helpful thing. But there is a thing called validation theory and validation therapy, espoused by Naomi Fell, and she's got some fantastic YouTube videos that you could look at. And what she would say on that point is what people are asking for is the comfort that comes from having their mother or father around. And so you can try to engender that by picking up on that thing and go, oh, your mum sounds like an amazing person. Tell me about her. And start a conversation along those lines, build rapport, and then move it on to the thing that you want to talk about. And that often works really well for reducing some of the agitation when people are living with dementia.
That sounds fantastic, actually. And we'll certainly put links in the show notes to validation theory. James, to yourself.
Yeah, I think it's probably worth reflecting here on, or certainly what one of the strategies we have when we're educating our teams is to actually try and use simulation a bit around this. So actually, one, around a scenario, and albeit, you know, it's artificial, but actually it can be a good construct to educate and train the team as to how to approach someone who's living either with dementia or in an acute delirium episode. But also actually to train them in how terrifying it must be to be living with dementia, often in an alien environment, particularly in hospital. And it must be pretty awful and agitating having acute delirium, particularly with sensory impairments, which just compound the issue massively. So actually we have sensory impairment equipment now. So we basically put our practitioners, when we're training them, in these frailty suits. So actually it's difficult to function. It kind of simulates the sensory impairment kind of perspective for them. So actually it's a way to engender this kind of empathy really with the patients that they're seeing. And the hope is that we can build in all of the techniques that Iain has described around how we, one, empathize with them, two, there are basic sort of things and interventions that we can put in place around, you know, glasses and all the rest of it, but also, and how we can sensibly communicate with people who have cognitive problems. I think the reorientation thing is something that really gets missed on ward rounds and in hospital. And in general, to be honest, there are really simple strategies that the multidisciplinary teams should be using that can definitely help.
Something which you both picked up on is this role of empathy, and how it's central sometimes to interaction with patients which are confused and/or delirious. Could I get you to speak to, and Iain, I'll come to yourself first, around how we can improve patients' overall care experience using empathy as fundamentally as a tool?
Yeah, so I think empathy is at the core of everything that we do, isn't it? And in the relative rush and hubbub and stressful moments, it is one of the things that sometimes can fall a little bit by the wayside when people are trying to be quick or speedy and such like. And there's such a drive for us all to try and do that and work faster and work harder and do more. We have to resist that at every possible moment, and we have to do the right thing for the patients that we're with, and that is about building rapport, getting to understand them, investing a bit of yourself in that person, and managing them with empathy. If we talk about people living with dementia, there's the Alzheimer's Society talk about people's communication and memories being divided between those memories of words and those memories associated with emotions. And they talk about this analogy of bookcases, where the books on the top of the bookcase are the most recent memories that you have, and the ones at the bottom are the lower down ones. And you've got two bookcases, one bookcase that have got your memory of events and one your memory of emotions. And the bookcases get shook around, and some of the books on the top fall off, and so you lose some of your recent memories for events. But the ones further down hang around for a while, but eventually they start to fall off as well. The emotional bookcase, though, is a bit like something from Harry Potter. It's got chains attached to the books. They hang around for a little bit longer. They can take a bit more shaking. And if we don't look after people with empathy, what happens is that they feel that they've had this bad interaction with somebody. They feel angry, upset, but they don't know why. They can't remember the why, because the event has gone, but the emotion is hanging around. So if you manage people with empathy, even if they cannot remember 5 seconds later what you said to them, they will remember a nice feeling of that person was nice to me, or someone has been nice to me. And that is so easy for us to do, and so important, and improves somebody's quality of life there and then in that moment. I don't think we can deliver healthcare without doing that correctly, and we have to remember that.
Yeah, indeed. That's profound, actually. That's absolutely profound. James, to yourself.
Yeah, when I was doing a little bit of research on this, there is actually some evidence behind the use of empathy out there. So, I mean, Iain, totally supportive of everything that he's articulated there. But actually, there's some analysis around, or an evidence synthesis around use of empathy, and those who studied this in sort of, I don't want to call them delirium survivors, but those who've actually had episodes of delirium, and when we've analysed what their experience has been, actually the best outcome, ones with the better outcomes had really positive experiences involved in their care, and that involved the core empathy of the staff dealing with them. So they felt supported, they felt more loved. They felt there was a trust there with that between them and the staff looking after them. They felt like they were supported in understanding their own condition and actually in their own autonomy. And it's that reassuring positivity, participating in certain things on the ward and being respected were all the key elements that were pulled out in the literature when they looked at this. So that is evidence, as far as I'm concerned, that actually the things that we innately know are true and that we should be doing day in, day out is supported by the science behind this. So that's all I wanted to add there, because I think Iain covered it really well.
No, absolutely. And exactly. And as Iain said, what I really find is that tonality and intonation. So it's almost not what the spoken word says, but it's the way it's said, and it's also, it's the care, it's the love, it's the attention, and it's the tonality. One of the things I would like to pivot to and get both of your thoughts on is really how, so in a very time short, or we're very time poor in clinical environments, which we all live in really, but certainly in an acute sense. Iain, I'll come to you first about how we adapt communication to reduce anxiety and confusion in elderly patients. Just as an example, as a paramedic, I used to just use kinesthetic touch, just touch a hand, just to let them know I'm there. And even if they can't really grasp the gravity or indeed all the action around or the movement around, that there's someone enduring in that space who just has that simple touch connection. And that seemed to sometimes be the leveler and just really build that rapport. Could I get you to speak to that?
Yeah, sure. I think that's exactly it, isn't it? It's, if you think about someone who is, irrespective of whether or not someone has a cognitive impairment, there is a degree of anxiety and worry when a paramedic turns up. You don't call them randomly. You call for help when you need help, and if you're having chest pain, if you're having difficulty breathing, there's an anxiousness there. And someone that's living with dementia has exactly the same thing. They don't suddenly become a different person. They may not be able to express that to you, but they have exactly the same fears, worries, maybe hopes and aspirations as we all do. And so I think the treatment of that is the same way that you would treat anybody else is with empathy and compassion, and say, look, this is really difficult. I can imagine you're finding this. You're very worried about what's going to happen. We're here. But doing that in a way that's understandable. So short sentences, nice and clear. Touch is important, like you say. And I think in some ways, touch without lots of plastic gloves on and stuff. Like actually human touch if possible. And lots of eye contact, smiling. Spending those. It's only seconds, isn't it? It's a few extra seconds. It's not hours and minutes and minutes. It's a few extra seconds. Just making the eye contact, looking in the eyes. Go, it's all right. We've got this. I think that's it. I don't think there's anything particularly special.
Yeah, James.
I'm not sure I've got anything to add to that. I mean, I think it is pragmatic, sensible, common sense stuff, isn't it? And I mean, I know we're going to touch on families as well, but I think all of the things we're saying are applicable to caregivers and families and loved ones. So actually, it's not just the individual with delirium and acute confusion or dementia that you're dealing with. You're dealing with their whole entire support network as well. And I think the same degree of in-depth communication, strategies to tackle that, empathy, understanding how distressing the episode of delirium can really be for them, sometimes more the individual who's actually living with it, is really, really important as well. So I think, spending and devoting that time to the patient is obviously massively important with all of the things that we've described, but it is equally as important to spend that time to gather the information you need from the family and caregivers, as well as articulating exactly what's going on day by day. So actually, it's really, really hard condition to not just treat sometimes, but actually to explain. So actually, in lay person's terms, all of the things that we're thinking, that relaying them to the individual who's really worried and distressed about their loved one is really, really important as well, and a key skill.
So let's go there actually. And James, I'll come to you first around families, because I think sometimes, as you were saying there, the missing part of the puzzle sometimes, because as Iain said, it's about appreciating baseline. And one of the things it's difficult for pre-hospital and in-hospital providers when the patient is not familiar, or indeed there's no patient notes, is that what is their normal baseline? And it's hard to appreciate that. But families have a good semblance of that. They've got a good sense of baseline. They live with them. They understand what's normal, what's abnormal. But you're absolutely right getting the family on board. James, could I get you to speak to just really strategies really for engaging the families? Iain spoke to chunking information down, and I think this is sometimes fundamental, because all three of us have been to clinical cases where if information is not in non-medical terms and is easily engageable with, it's very hard to retain and then reiterate that information. But could I get you to speak to how you engage families and bring them along on the journey for someone with delirium?
Yeah, and so on this, I'm going to go back to frailty again, because actually the vast majority of individuals I encounter who have delirium will be living attached to the rest of their body, which is often has a degree of frailty. Okay, so actually these are people living with complex needs, and absolutely their core support network is fundamental to understand as part of that sort of syndrome. So it's not just about the delirium, it's about their whole person, and actually how they are living at home, all of that collateral information, that the rich source of information, if you spend time with families and carers, that they can give you is really, really vital. And they can tell you a lot. They're often part of the solution to potentially reversing the delirium as well. So actually building them into your strategy, putting them in as part of the team. They're part of the MDT and the multi sort of modal. I wouldn't describe it like that to them, but they are part of a multifaceted intervention almost. You want to maintain normality for that individual as much as possible. And part of that is obviously going to be a familiar voice. It's going to be someone that they love and who's going to dedicate their time to them. So I think that they are a vital adjunct to a lot of the strategies that you have to help manage the behavioural aspects of delirium and to help orientate and occupy patients. And obviously, as you described, they're a vital source of information, aren't they? You know, that we try and capture that in detail as best we can. So there's something called the This Is Me passport, which we've tried to embed in all of our pathways, certainly on our frailty units, which it's an attempt to capture really the daily life of an individual with cognitive problems. So actually their likes, their dislikes, what they can do, what they can't do, what they like to eat and drink, you know, all of those aspects that we take for granted that someone so vulnerable with their cognitive problems can't tell you about. So it's a mechanism to engage the families in capturing that key collateral information. I would also say they play a part in telling you if something's wrong. So actually, it's often the carer or a living carer or someone who knows that person with pre-existing cognitive problems really well. They are often the ones saying that there's something up here. You know, they're just not quite right. There's this really early soft signs that delirium might be happening. They're often the ones that will flag it. And they can get dismissed. So actually you say, well, actually, no, this is someone with dementia. What do you mean? Actually, I would never dismiss someone who knows and who looks after and is close to someone who has a cognitive problem, because 9 times out of 10, they're definitely going to be right, that there's probably something going on that is causing a crisis or an acute confusion. And obviously you need to know who you're talking to, I would say. So for teams who are out there, actually clarify who they are. And you know, are they an advocate? Are they an official advocate even? So do they have lasting power of attorney? Because actually that's really important to know. And it's a key part of the handover as well, if you're handing on the care of the patient.
And Iain, to yourself.
Yeah, so I think that involvement of the relatives is absolutely key. And one of the, I guess, the diagnostic tools, screening questions for delirium is a single question in delirium. Is your loved one different to how they usually are? And I think that's one of the most, almost sensitive tools that you can use. The 480 is also helpful. And there's various other assessments that you can do with family members to try and work out what someone's baseline cognition is, that you can even use when they have delirium. So the IQ code or the 88, a couple of others. But I think, as James said, involving the family as a diagnostic and a therapeutic intervention, actually, I think is absolutely key.
Just looking and pivoting slightly to how we can start to align care, really, because you're right, there's continuity of care across the spectrum. Transitions of care can and historically have been some of the riskiest parts of the patient journey because of information entropy or because of maybe confirmation bias and certain elements which either aren't passed on or transferred. Could I get you to speak to, and Iain, I'll come to you first, around just how we can align better between pre-hospital and in-hospital teams to manage delirium, manage some of these acute infections, dehydration, and or effects of medication?
I think you're right. I like your word, information entropy. I like that. And I think one of our jobs is to resist entropy, isn't it? Is to try and present information in a way that there is a shared understanding and a shared narrative, a shared lingo, whatever, and then people know what we're talking about, and then the right message gets passed along, and then that's more likely to be perpetuated. So I think things such as this, us having a joint shared conversation about delirium, joint shared learning. The BGS has the delirium e-learning module. It's about 8 hours of e-learning and is excellent. We've done MDT episodes on delirium and cognitive impairment, such like that people can seek out. And I think trying to have a shared understanding of what it is that you're talking about. And I think some of that actually, in terms of delirium, is the word delirium, is saying this person has delirium, not they're a bit muddled or they're a bit confused or even they have an acute confusion. Just, let's call it what it is. This person has delirium, or I suspect this person has delirium, because that then sets you down a pathway. And if things don't fit, we can come back and revisit that. But actually, you need to be on a pathway, and that sets things up. And I think, if we thought someone had a heart attack, we would say, I think this person got a heart attack. Delirium is just as risky as end-stage heart failure if you arrive in A&E with delirium. And so I think it's about calling it out and saying what it is. And I think once we get that right, then actually the rest of the continuity of care is so important, but we're starting in the right direction. If we get that bit right, a lot of other things get easy.
James, to yourself.
Absolutely. And we know, things like stroke and heart attack management, that we've streamlined that, haven't we? The pathway of care starts in the pre-hospital assessment. Everyone understands it. The diagnosis is there. And actually, they're going to the right specialist team. And there's the care bundle that's there, and everyone is trained in it. And, we audit it in the acute trust. And the pathway is evidence-based and succinct and streamlined, and everyone in the system gets it. We need exactly the same for delirium management, basically. We need to have all the teams attuned to understanding it, educated and trained. And actually, that care bundle starts with the pre-assessment, doesn't it? There's the acute bit that they need to get right. So recognizing it in the first place, calling it what it is, gathering that key information that might be critical to actually diagnosing the underlying potential causes early, as well as all of that collateral information about the individual and their background. And then actually, as part, you would hope that there's that pre-alert system into the right system and the right handoff of care into the right multidisciplinary team. So and actually, one of the things that I've seen that's really powerful was in Scotland, where they had a time care bundle, I think it was, which was an attempt to use quality improvement to embed a whole system pathway of care nationwide. But actually, the literature behind it is really quite good. So that is something that I would encourage people to go and look at. People think that these things are impossible, but if we can do it for pathways of care where the disease, based paradigm is quite obvious, we can do it for something like delirium.
There's a number of good studies as well looking at a lot of the delirium research is done on patients with neck of femur fractures, because you've got a 50% of chance of being delirious. And so there's studies where I think it was a Scandinavian study, and essentially gave everyone oxygen. They gave them some fluid. They gave them a standardized anesthetic regime. They looked for delirium pre-hospital ED and afterwards. And they expedited surgery as soon as possible. So none of those things are particularly thorny to deal with. And the delirium rate went down by 35%. And that when you've got a condition that's got mortality and morbidity as high as delirium, a 35% reduction is astronomical.
Matters.
And has massive long-term effects. And
we know that there are studies, aren't there, in general, that basically a lot of it is preventable. The incident delirium and from hospitalization, we can prevent 30 to 40%. So there has to be something around how we standardize that approach, doesn't it, off the back of what Iain's just said?
Well, Iain actually said this in the last episode, which was absolutely excellent. And I'd just like your take on this, actually, James, because Iain said, hospital poses a significant risk for frailty and for frail patients, that actually, if they don't need to be there, there can be a whole array of infections, acute infections, which incites delirium and can be the focal diagnosis for delirium. So actually mitigating the need to go to hospital and streaming them into a different pathway might actually do the patient far more proactive benefit than actually going to A&E at all. Could I get you to speak to utilization of pathways?
Absolutely. It goes hand in hand with all the things that we've mentioned before around early identification, knowing it exists and it's there, and early comprehensive geriatric assessment by the right multidisciplinary team as soon as possible. And actually, I would say delirium in an older person is an index condition where all of those things apply. So just like with any kind of frailty syndrome or frailty crisis. So certainly in our system, if we get a call in our single point of access, our advanced clinical practitioner will take that call directly from the paramedic. They will have a two-way conversation. They will have a clinician to clinician conversation about the person at home. And then we will deploy our 2-hour response team to go and deliver urgent comprehensive geriatric assessment. I can't give you a figure, but a high proportion of those individuals will have concurrent cognitive problems or a delirium episode. And we know all of the evidence base behind pathways of care and the early intervention under the right multidisciplinary team. We know that it minimises the risk of hospitalisation. We also know that if you organise frailty units and care for older people in general, but those with delirium as well, that it leads to improved outcomes if they have to be in hospital too. So I think whatever the health and care setting, it's those principles that apply and are really, really important to improve outcomes. I think it's particularly difficult with delirium sometimes. I have to say, as a condition, it can be very, very tricky once someone has landed in an acute hospital bed to actually manage that care out of hospital. So actually capturing them in the pre-hospital phase has loads and loads of concurrent benefits, because you're actually minimizing the risk of worsening the delirium through that environmental change. And I wouldn't underestimate the impact of a hospital environment on cognitive state. It is one big deconditioning, sleep deprivation unit often for older people, basically. And that's how I often describe it when we're managing risks and benefits with families and caregivers, that actually it isn't a place of safety often for people with delirium. It can be really deleterious to their health and care. So it's flipping the whole risk conversation. It's flipping our whole mentality around how we manage this condition outside hospital.
Iain, could I just pivot slightly and just come to you around ethical and family considerations, really, and just maybe ask you initially around how you approach situations where families advocate for interventions that may not be aligned to patient wishes and or care plans for the patient. Could I get your approach, and then I'll come to James afterwards, about how you sort of navigate these tricky conversations, sort of family wishes versus patient wishes?
Yeah. So I think there's an easy answer and a reality. I think the easy answer is you follow the Mental Capacity Act, and you work out whether or not the person has capacity, and if they do, you do what they want, and if they don't, then you act in the widest sense in their best interest, and that involves conversations and discussion with friends, relatives, carers, such like. Within that, there's a lot of nuance, isn't there? And we've all had situations where patients and relatives and loved ones may want one thing, and the patient may want something else, or it may be in our view that the best interest is for a different decision. And I think I feel like I'm saying the same thing. Actually, you have to manage these situations with care and with empathy and compassion, and understand that. Well, first of all, understand that we're not always right. Just because we feel that this is the right in inverted commas thing to do, doesn't mean actually that it is, and that's where the Mental Capacity Act helps, and the best interest assessment process. But also the people care generally for their loved ones, and they are advocating for what they think is the right thing. And I think, in common with any decision, you have to make sure that the person that you're having that conversation with has the information that they need in order to make that decision. And that is the sort of conversation that James was just describing, actually. If we take the example of coming into hospital, is that actually coming into hospital isn't a fix-all for everything. In fact, it may actually make things quite a lot worse. And so it's about knowing the information about that, being able to explain that, but also being able to explain what the alternatives are. And as a system, us developing alternatives that work and that we can access, so that you as a pre-hospital clinician can pull those levers, and you have some levers rather than just well, you can stay here or you could come to hospital. You need the variety of options, and you need to know that they're going to be there at the time that you need them. And that's a more complex system-wide thing. But I think at a basic level, it's about making sure that the person you're having the conversation with has the information that they need in order to make an informed choice, whether or not that's the patient or the patient and the relatives as part of your best interest conversation.
And James, yourself.
I think this is probably the most tricky area of being a healthcare clinician, isn't it? And it's not taught particularly well. I mean, my experience in medical school was long ago, but I'm sure it's improved since then. But actually, these are the really tricky conversations to have sometimes. And actually, no one likes articulating that the recovery may be poor. And in particular, I think it's really hard where there's no binary black and white solution to what's going on, that there is real uncertainty. And actually, people don't like living with uncertainty in general. None of us do. Actually, we want clarity about what's going to happen with the ongoing care and recovery. And often in delirium, sadly, we know that the outcome can be quite poor, that actually mortality risk is high, and that actually the need for ongoing 24-hour care beyond a hospital admission is very high as well. And actually that individual may never see their own home again. All of that is really, really tough to deal with and uncertain. And we can't promise that actually a deterioration won't happen off the back of the admission either. What I would advise people is to never fudge it, to actually be really objective, and to actually almost reduce the emotion around it, and to actually be quite factual around the case that's in front of them. People really appreciate it when you're honest, and actually you tell them what you're really thinking as a clinician about their loved one. Actually, they're the vast majority of the time really, really appreciative that you've had that conversation. So I'd really, really encourage people to do that. And I think the tricky ethical things, that the common cases are really around respect forms. People might not understand what you're trying to say around resuscitation and poor outcomes. But actually, if you do it right, and there's certain key phrases that I would use when describing resuscitation attempts and things, actually 99.9% of the time, it's not an issue. It's all about good communication, really, and explaining the facts. Also, I would say around feeding, that tends to be quite a big one as well, that actually swallowing impairment is common in older people in general, but actually in cases of delirium and those who are stuck in hospital in crisis, it can be quite an issue around nutrition and swallowing impairment. And actually a best interest conversation needs to be had around a high risk feeding strategy, that you're going to do your best to minimize the risk of aspiration and worsening the chest, but actually it's probably the right thing to do, rather than putting that individual through unnecessary medical interventions. And actually pragmatism is the other thing that we try and teach people, that often where there is a very narrow reversibility, that there is very poor reserve, that there's potentially quite a very poor outcome, and that this person's probably entering their last phase of life. Do we really want to be doing observations in the middle of the night, as happens in hospitals? Or do we want a more pragmatic approach to their health and care interventions?
As we come into land in the conversation, Iain, if I could just come to you initially, just to speak to just training and evaluation, just what feedback mechanisms and or metrics we can really look to implement or indeed assess the effectiveness of our management strategies for delirium in hospital or indeed pre-hospitally?
So I think ultimately we want to have management strategies that are effective at, firstly, reducing the severity of delirium. Secondly, reducing the incidence of delirium. And so I think in terms of that, that's what we'd be looking for. Now, in order to do that, actually, there's a bit of pre-work to do, which is about to ensure that we're screening for it sufficiently so that we can actually then have a confident baseline to assess all of our quality improvement metrics and everything against. And I think that's probably where we need to be, actually, is now thinking about, and it is national guidance, but really embedding that so that every single person, whether or not that we think they need it or not, has a degree of a cognitive assessment when they arrive in this situation at our hospital. And that doesn't necessarily, there is nothing wrong with us doing that at home before they start coming, and then again repeating it in the ED and repeating it on day 1 or day 2 in acute medical surgical units, wherever they are. But I think that's probably where we need to get to, because then actually we can then screen properly for delirium, which means our diagnostic rate is going to go up, and then we've actually got some something that we can actually see an effective change for the things we've talked about and the stuff that's covered in the educational programs about delirium prevention, delirium management, and such like. I think at the moment we're not accurate enough and reliable enough at doing those assessments to be able to show the thing you're talking about effectiveness of education.
And James, to yourself.
Yeah, I mean, totally reinforce everything that Iain has touched on there. And I'm going to plug the GIRFT triple assessment tool again. So that's use of News 2, CFS scores, and the 4AT. And actually, as Iain said, we can do that in any healthcare setting. So actually, the pathway of care starts in the person's own home. So if we can standardise that clinical assessment and triage consistently across the pathway, we should see the ongoing benefit. The benefit should fall out really from doing that. And I think prevalence of delirium would be a big one at a population level. So actually, if we can prevent 30 to 40% of incident delirium, that's huge numbers of people, isn't it? And if we can measure that effectively with our performance measures, then that would be a very key pathway metric. And obviously the fallout from that is the system-wide impact, isn't it? So bed day consumption in acute beds, and actually outcomes from hospitalisation, I would say, should improve. So actually transfer to a new care home facility should go down if you're getting the pre-hospital delirium pathway right. And that's really, really important. And I would say post-hospital diagnosis of dementia might be a metric as well. Actually, if you're minimising that risk at the front end, new diagnoses of cognitive issues at the back end of a hospital pathway should improve. And I think there's probably some patient-reported outcome measures that we could think about around systems of care that are really frailty attuned and are attuned to delirium management. That's quite a key area of research and exploration at the moment. But I think there must be something around what older people are telling us around the systems of care that they occupy that we can capture, as well as that feedback from staff around their education and training and confidence in managing delirium.
I think that's a nice 360 approach actually to getting some evaluation and or feedback. Absolutely. We're going to leave it there. It just leaves me to say thank you both for the last hour. It's been fantastic just to really walk through delirium and confusion and indeed dementia and just everything that falls out of that actually. And we'll see you next time for part 3 with Georgie Gill and indeed yourself, Iain, on decision-making and communication within geriatric patients. But thank you to you both for your time today.
Thank you.
Thank you very much.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.